This morning's meeting of the Joint Standing Committee on Health and Human Services. Welcome on a chilly Friday in the great state of Maine. We are assembled around our virtual horseshoe, and we're live streamed on the HHS channel found on the Maine State Legislature's YouTube channel. You can find the replay of our proceedings should you miss us live. This morning, we will hold public hearings on 5 bills in the following order: 1333, 789, 1177, 1428, and 1487. For those testifying, please make sure the name you're using on the Zoom webinar matches the one you used when you signed up to testify, and we would ask that in order to help our clerk manage the attendee list, you exit the webinar once you've finished your testimony, answered any questions from the committee, and watch the rest of the hearing live on YouTube. We'll be taking testimony in the following order: the sponsor, any co-sponsors, and other legislators, those providing testimony in favor of the bill, then those opposing the bill, then finally neither for nor against, but with additional information for the committee. We do run a 3-minute clock on testimony, and you'll receive a prompt when you have 30 seconds left asking you to kindly bring your testimony to a close. Public hearings are just that, for the public. The process of hearing testimony certainly engenders and encourages probing questions, and the committee is asked to use the raised hand function in order to ask those bill-related questions. With that, we'll do a quick round of introductions around the horseshoe, beginning with Representative Zager.
Thank you, Madam Chair. Good morning, everyone. My name is Sam Zager. I represent District 41 in Portland.
And Representative Connor.
Thank you, Madam Chair. Good morning, everyone. My name is John Connor. I represent House District 58, which is part of Lewiston.
Representative Craven.
Thank you, Madam Chair. Good morning. I'm Margaret Craven, and I represent House District 59, which is part of Lewiston.
Representative Javner.
Good morning. I'm Representative Kathy Javner, and I represent House District 141, which is located in Penobscot and Washington counties.
Representative Griffin.
Good morning. My name is Abigail Griffin. I represent House District 102, which is Glenburn, Levant, and Kudeske.
Senator Moore.
Good morning. I'm Marianne Moore, and I represent Senate District 6, which is all of Washington County, as well as Goldsboro, Winter Harbor, and Sullivan in Hancock County as well.
And I am Representative Michelle Meyer, proudly serving Southern Maine's House District 2, which is Elliott, where I live, and parts of Kittery and South Berwick. I am the House Chair. My Senate co-chair has a commitment in another committee. With that, I also want to introduce our analyst, the committee analyst, Erin.
Good morning. My name is Erin Dooling. I'm one of the legislative analysts for this committee.
And our committee clerk.
Good morning. My name is Carrie Withy. I'm the clerk for the Health and Human Services Committee. If you need any assistance during the hearings this morning, you can email me at hhs@legislature.maine.gov. Thank
you. With that, I will open the hearing on LD 1333, an act concerning dispensation of naloxone hydrochloride by emergency medical services provider, and welcome its sponsor, Representative Sam Zager. Sam.
Thank you very much, Madam Chair. Good morning again, everyone. And I want to thank the committee for adjusting the order, and thank other sponsors and testifiers from other bills for the flexibility. For the record, I'm representing District 41 in Portland, and also a former ambulance crew member and current family physician. Part of my practice is indeed caring for folks coping with opioid use disorder. I'm pleased to introduce this bill, which I wish we did not have to do, but I appreciate that Gordon Smith, the Director of Opioid Response, asked me to introduce as amended. I thank him and Sam Hurley, the EMS Director, for the collaboration in and the opportunity in this bill to help save lives. Unfortunately, Maine continues to be in the grips of the opioid epidemic. Fatal overdoses in the first quarter of this year, averaging over 10 deaths each week. LD 1333 as amended is one simple step this legislature can take to save more lives. I care so much about this bill because I know that the availability of naloxone greatly influences how many Mainers can make the journey from overdose victim to healthy, fulfilled, and productive individual. We all benefit from that. And it's specifically referenced in the updated opioid response strategic plan, which was presented to this committee by Director Smith earlier this year. Under current law, police officers and fire department personnel can distribute naloxone, and many do. EMS providers should, of course, be allowed to do so because they're frequently the first ones at the scene of an overdose. The proposed committee amendment A would replace the entire bill and would allow EMS personnel, ambulance crews, and other non-transporting emergency medical services to dispense, not just to administer on this in the moment, but also to dispense life-saving naloxone to an individual who is at risk of an opioid-related drug overdose, or to the individual's immediate family, friends, or other person in a position to assist. Currently, EMS personnel, as I said, can administer, but the EMS personnel cannot give a take-home kit, if you will. I apologize for missing this during the revision process, hence the Amendment A. The Office of Opioid Response has advised me that the person most at risk of having a fatal overdose in Maine is the individual who overdosed this week but survived. It's a marker of risk. The best chance to get this individual Narcan or naloxone and to connect them is to connect with them while they're still at the scene of the overdose. In fact, 1 out of 7 or 14% of these individuals refuse transport to an emergency hospital department. I'm going to skip over the additional points in the written testimony for the sake of time, but I do call the committee's attention to that in my submitted testimony. The other amendment in this bill would permit medical directors of federally qualified health centers and group practices to gain access to the prescription monitoring program for prescribers at their practices, the ones that they are overseeing. This authority already exists with hospital chief medical officers. And this committee expressed interest and support for this idea in an earlier bill as an amendment, but opted not to include it in that bill because the interested parties had not been notified in time for that piece to have a hearing. However, in this case, the interested parties have been notified of the amendment in relation to this bill. It's something that is a bit of a technical fix. It seems bizarre that FQHC and group practice medical directors can't look at the PMP for patients in their practice. And this bill is certainly in the same realm as that. So hence Amendment B. I thank this committee very much for consideration of LD 1333 and the amendments. Be happy to answer any questions I can and defer those I can't answer to the directors who are going to follow me in testimony. Thank you so much.
Thank you, Representative Zager. Questions from the committee for the bill's sponsor? Seeing none, we wish you a great day seeing patients today.
Thank you. I do have a few minutes, so I'm going to stick around as long as I can. Thank you so much.
Sounds great. Thank you, Sam. Presenting testimony next is Director of Opioid Response, Gordon Smith. Welcome.
Good morning, Representative Meyer and distinguished members of the committee. I am Gordon Smith of East Winthrop, the state's Director of Opioid Response. I'm testifying this morning from my beautiful cubicle in the Cross office building, and that means I have a split screen, so to see you, you're going to get a bad profile of me. So while I'm testifying, at least, I'm going to be addressing my laptop. I am really pleased to be able to support LD 1333 in my capacity as the Director of Opioid Response, working in the Governor's Office of Policy Innovation and the Future. When you very graciously provided me an opportunity earlier this session to brief you on the updated Opioid Response Strategic Action Plan, I noted this bill, which is specifically referred to in the plan as part of our harm reduction activities. I share in the responsibility for the bill as printed not being the correct draft, and I apologize for that error. I did a fair amount of research to find out what did occur, and if you really want to know how it happened, I have that information. But I do apologize for that error. Representative Zager has furnished you with the correct language in the proposed committee amendment, which I appreciate. The language in the amendment, if enacted and signed into law, would allow EMS personnel to furnish individuals at risk of an overdose with naloxone when authorized through a standing order and protocol issued by EMS Medical Direction, the EMS Medical Direction and Practices Board. Sam Hurley, our Director of EMS, will testify in support of the bill and can address any questions you may have about how that board operates. As Representative Zager has noted, we are still experiencing a high number of fatal overdoses. We are averaging so far this year about 11 fatalities a week, a truly horrifying number to the governor and I'm sure to you. But for every fatality, there are several saves, which provide an opportunity to connect that individual, excuse me, with harm reduction services, including a double dose kit of Narcan to take home. The new options program is also available to connect the individual with services or a pathway to recovery if the individual is ready to start that journey. Naloxone is a remarkable drug that blocks the effects of the opioids. It is safe, not subject to abuse, and since first being authorized in Maine, it has saved the lives of at least 2,000 Mainers. It's probably a conservative estimate. It can very quickly restore normal respiration to a person whose breathing has slowed or stopped as a result of overdosing with heroin, fentanyl, or other opioids. Unfortunately, the medication is not effective in reversing an overdose from non-opioid substances such as cocaine, meth, or other stimulants. While naloxone is available in different forms, including an injectable product, it is anticipated that the nasal form, under the brand name Narcan, will be the form of naloxone distributed by EMS. Executive Order 2, issued by the governor in February of 2019, authorized the state to use federal funds to purchase Narcan kits. And since September of 2019, about a year and a half ago, our naloxone distribution network has purchased with these federal funds and distributed over 60,000 doses of Narcan. The Attorney General's office also continues to distribute 625 Narcan kits every quarter to law enforcement agencies across the state and tracks the number of saves. I believe that the federal funds available through the Office of Behavioral Health are sufficient to purchase the additional kits that would serve the interests of this legislation. And I know Dr. Pollard, our director, is going to testify on the bill as well. Police and fire officers can, as Representative Zager has said, under existing law, distribute naloxone. In my opinion, at the time they were permitted to do this in the original legislation 3 or 4 years ago, EMS should have been added at that time. It is time now, given that they weren't added, for them to be able to distribute it as well as administer it. If there is strong support for the bill, I would ask that you consider an emergency preamble. When lives are at stake, the sooner we can do this, the better. I also support the Second Amendment and really appreciate the committee working with your staff to try to find a vehicle to allow medical directors of these practices and federally qualified health centers to check the PMP for their prescribing, for their prescribers. After all, they bear some legal responsibility for supervising those scripts. And so they should be able to have the ability to go in and access those records, just as the medical director of a hospital can. That's been something I've been trying to fix for 3 years. And I appreciate that you might be able to use this bill for a vehicle. Thank you for the opportunity to testify. Happy to answer any questions you may have, certainly available to you for a work session. Thank you.
Thank you. Questions from the committee for Director Smith? Seeing none. Yes, Representative Javner.
Thank you very much, Chair. Dr. Smith, I just have a couple of quick questions. I too was actually asking about the emergency preamble and why there wasn't one already on here. So I think we can certainly assist in that for sure. I have questions about you said that there were 60,000 naloxone distributed.
Yeah.
Do we have data on how many have actually been used? How do we track those? Is there expiration dates?
Mhm.
What's the actual process of the utilization of that?
Thanks for the question. And I'm glad you asked the question because I was in your district yesterday in Springfield, in the middle of your district, visiting the new soon to be open residential treatment center. I couldn't be more enthused about that facility. To specifically answer your question, we have a naloxone steering committee. We call it now the main naloxone distribution network, and 3 entities in the state use our federal funds under contracts with us to purchase and distribute within their geographic region. That's the Bangor Public Health, a department of the city of Bangor, Portland Public Health and Human Services Division of the city of Portland, and Maine General Hospital. And we do track, we call those the tier 1 distributors. They distribute the kits to the tier 2 distributors. Those could be a syringe exchange, it could be a treatment provider, it could be emergency departments, could be a fire department. And then our research team at the university, led by Dr. Sorg, track all that data, and we meet every month. So we could, at the work session, quite easily bring you in quite an extensive report on where that naloxone has gone. It's not cheap. We buy it for the double dose for $75. It retails at a pharmacy for $150 if you were to go in and pay cash for it. So there's a lot to it. I think when the governor and I announced this on February 6th of 2019, I'd only been in the position for 2 days at that point. And so I actually had no idea how long it would take through the state procurement policies to get the first dose purchased and distributed. And it was about September. But it is now quite an effective distribution network, and it is saving lives across the state. So when I say 60,000 doses, realize that that's really 30,000 kits because there are 2 doses in each kit.
Okay. Thank you
Follow-up
very
question?
much. Yeah, thank you, Dr. Gordon. Dr. Smith, I appreciate that. And also, I apologize that I wasn't able to be with you yesterday in Springfield.
Well, I've been there four times now. I didn't know there was a Springfield, Maine until 6 months ago.
I love it.
You have a beautiful district, and
It's the best.
and that's going to be a beautiful facility. As you know, it's a school that was closed and consolidated as an elementary school with another school, and it's a beautiful 12 to 16 bed facility for men and women, hoping to open probably in July. I should correct you, Representative Jabna, too, that I am not a physician, I'm not a doctor, I am a lawyer, as some on the committee are. It's a frequent mistake, and sometimes I just let it pass, but I want to make sure that people on the committee understand
Thank you for that correction.
Unlike you, Representative Zagar and Senator Claxton, I've never treated a patient. I'm just a country lawyer.
Thank you. Thank you for being here today. Seeing no further questions for Director Smith, we will move to Mr. Hurley. Welcome.
Good morning. My name is Sam Hurley, Representative Meyer, and honorable members of the Joint Standing Committee on Health and Human Services. I am the Director of Maine Emergency Medical Services, or Maine EMS, within the Department of Public Safety. I am testifying on behalf of the Department of Public Safety and Maine EMS in support of LD 1333. In 2020, EMS clinicians across the state of Maine administered naloxone to 962 patients, suspected of experiencing an opioid-related overdose. This life-saving medication, naloxone or Narcan, is critical to saving these persons' lives in the event of an overdose. The state of Maine has been working diligently to ensure that persons at high risk for overdose are eligible to get naloxone through their pharmacy or through programs administered by the Maine Department of Health and Human Services, as detailed by Director Gordon's testimony. Several research studies have shown that there is a significant linkage between non-fatal overdoses, so those where we were able to revive someone, and fatal overdoses that occur within a 1-year time span. For this reason, it is imperative that we outfit these individuals who are at higher risk with resources and support to help mitigate their morbidity and mortality. The Maine Department of Health and Human Services, in collaboration with various other stakeholders, including the Department of Public Safety, have been working to build out programs throughout the state to support persons experiencing substance use disorder and their families. This bill is yet another extension of that effort to ensure that EMS clinicians, EMTs, AEMTs, paramedics, post-resuscitation following the administration of naloxone can dispense leave-behind naloxone kits to the patient, their family, and or their friends. DHHS Tier 1 naloxone distributors, as detailed by Director Gordon, have partnered with many emergency departments across the state to ensure that patients who are treated in their facility for an overdose are discharged with naloxone. However, not every patient who receives naloxone from EMS gets transported to the hospital. In 2020, 14% of the 962 patients refused transport to the hospital after being resuscitated by naloxone. This currently represents a missed opportunity to provide these individuals and their families and or friends with life-saving medication and education, as EMS clinicians are currently not authorized to dispense medications, only administer medications. This legislation authorizes Maine EMS to expand our current protocols, as authored by the Maine Medical Direction and Practices Board, to allow EMS clinicians to dispense the naloxone nasal spray to ensure that family members and persons and friends of the persons experiencing substance use disorder are empowered to help save their loved one's life. We ask the committee to consider adding an emergency clause to this proposed legislation to ensure that EMS clinicians can get this medication in the hands of those who need it most as quickly as possible. Maine EMS continues to work extensively with Director Smith, Maine DHHS, the University of Maine, and various other partners to strengthen our unified statewide response to this epidemic that continues to affect our state and its residents. We see this capacity to dispense naloxone as yet another tool in our tool belt to help support persons affected by substance use disorder throughout the state of Maine. I appreciate your time and consideration of this bill and would like to reiterate our complete support of its passage, including the emergency clause. I'm more than happy to answer any questions that you may have at this time, but please feel free to reach out to me anytime if there's any additional information that I can offer you as a representative or senator and or the committee.
Thank you for being here today. Questions from the committee for Mr. Hurley? Yes, Representative Connor.
Thank you, Madam Chair, and good morning, Mr. Hurley. I just have one quick question. I was reading through the bill, and the summary, it speaks to EMS services being able to administer the drug after they've received the medical training in accordance with the protocols by the MD PB. Is there anticipated additional costs for that training that EMS personnel are going to anticipate, and will those costs be passed along in rates, or is that something that is just so minuscule? I just want to make sure I'm uncovering every rock and making sure everything is covered here.
No, absolutely. That's an excellent question. Thank you so much. So I believe is that the summary from the original language or the amendment language? So currently EMS clinicians at every level in the state of Maine are authorized and trained sufficiently on how to give naloxone to patients. So that's something that the investment has already been made, and it's part of standardized training. So the only training per se that they would have to do is how to train someone else to use the nasal spray. So they are all trained to use it. It's literally just walking through the instructions, which are printed on the back of these kits to say, here's how you use it. so that when they hand someone a kit, they're not just saying, here's a kit, good luck. It's here's a kit, here's how you use it. You take it out, you put it in their nostril, you push on the plunger, and it dispenses the medication and nasal spray. But there is no additional training required for them to administer because they're already using this and have been using it for over a decade.
I figured as much, and that seemed like common sense. I just wanted to make sure. So thank you for answering, and that's all I have, Madam Chair.
Thank you. Any other questions for Mr. Hurley? I hope that we'll see you at the work session, sir. Thank you for being here today. Representative Stover has joined us. Would you like to unmute and introduce yourself?
Yes, thank you. Good morning, everyone. My name is Holly Stover. I represent House District 89, including the towns of Booth Bay Harbor, Southport, Edgecombe, West Port Island, and part of South Bristol.
Thank you very much. Presenting, excuse me, next is Mr. Dingman. Welcome, Charlie.
Thank you, Representative Meyer and members of the committee. My name is Charlie Dingman. I am a lawyer with Kozak and Geyer in Augusta, and I'm here today on behalf of the Maine Primary Care Association, which is a membership association that includes all 20 of Maine's federally qualified health centers. Not surprisingly, the Maine Primary Care Association strongly supports Representative Zager's bill, particularly as it has been proposed to be amended by the work of Dan Moran at the Maine Medical Association, Gordon Smith, and Representative Zager. Maine's community health centers have long placed a high priority on effective countermeasures to address the opioid epidemic in Maine. FQHCs are currently working with Gordon Smith and Dr. Pollard and others to pilot expanded use of medication-assisted treatment in a variety of underserved locations around the state as a further step in that effort, which we hope to see expanded statewide ultimately. Their pledge to mobilize to provide an energetic and sustained response to the opioid crisis includes strong support for widespread availability of naloxone. A component of making naloxone accessible is addressed in LD 1333 as amended by ensuring that emergency medical service and ambulance service personnel can dispense naloxone hydrochloride in accordance with appropriate protocols. That closes a significant gap in availability. Likewise, as Representative Zager and Gordon have already testified, it is very important to provide medical directors at FQHCs with access to prescription monitoring program data. It's an essential tool in handling these prescription issues appropriately, and we welcome this amendment to the prescription monitoring program law. I would be happy to answer any questions, but I think that testimony prior to mine and doubtless testimony that is still to come adequately fleshes out the very urgent need for both of these measures. And we thank everyone for your creativity in getting the prescription monitoring piece into this bill.
Thank you. Thank you for being here today. Questions from the committee for Mr. Dingman? Seeing none.
Thank you.
We would welcome Jessica Pollard from the Office of Behavioral Health. Welcome, Dr. Pollard.
Good morning, Representative Meyer, distinguished members of the committee. I must respectfully request in the future if I could precede Director Smith, since he's a tough act to follow, and I confess I did not bring any fun facts about any of your districts. But I do have some data from our newly launched Maine Drug Data Hub, and I'm happy to share screen to address Representative Javner's question and provide some additional visual data context if that would be helpful. But I do want to point out the resource because it's available to you all at any time with some really great statistics on it that are updated regularly. In terms of LD 1333, I'm here to speak in support. Our Office of Behavioral Health, oversees both the naloxone distribution rule as well as the PMP rule. As amended, we understand this bill will allow EMS to dispense and distribute naloxone leave-behinds and certainly support such amended language. The interaction between EMS and a person experiencing an overdose represents a critical opportunity for life-saving intervention and connection to care. People with other comorbid conditions in addition to substance use disorder, such as mental illness or homelessness, largely lack access to any source of medical care other than that provided via emergency services. According to national research, about 15 to 20% of patients treated for non-fatal overdose by EMS are unwilling to be taken to a hospital for follow-up care. So this interaction may be the sole opportunity for providing a potentially life-saving connection to harm reduction and treatment resources. Recognizing the missed opportunity for intervention inherent to post-overdose transport refusal, some EMS systems have recently begun instituting public safety-based naloxone leave behind programs that allow EMS personnel to leave behind naloxone kits at the scene of an overdose. This model provides a direct distribution of naloxone kits to individuals who have survived an overdose, as well as concerned family, friends, or loved ones immediately following the overdose event. EMS naloxone leave behinds represent a unique opportunity to increase the availability of naloxone among those members of the community who are at greatest risk of experiencing or witnessing an overdose. Thank you for your time. I'd be happy to answer any questions and make myself available for the work session.
Thank you. Questions for Dr. Pollard? Seeing none, appreciate your being here today.
Thank you.
We would welcome Caitlin Morse to provide her testimony.
Good morning, members of the Joint Committee on Health and Human Services. I am Caitlin Morse, a resident of Westbrook and Policy Associate for the Alliance of Addiction and Mental Health Services. On behalf of the Alliance, I am here to speak in support of LD 1333. The Alliance represents Maine's safety net community-based mental health and substance use treatment agencies. We advocate for sound policies and evidence-based practices that enhance the quality and effectiveness of Maine's behavioral health care system. Behavioral health recognizes that the connection between behaviors and the health and well-being of the body and mind is essential. We work to make life easier for the providers we serve while believing that people who are suffering should be able to easily access the resources they need. I have a history of colon cancer in my family. I'm 34 years old. The doctor tells me I need to get a colonoscopy when I turn 40. Eating bacon is especially not good for me. I know the facts and I still eat bacon. Someday, if it should come to it, and hopefully it never will, I most likely will not be denied the treatment I need because I ate bacon on April 23rd. Just as I can easily get bacon at the store, even though it is not a good choice for me or anyone in my family, illicit drug use is part of our world. Illicit drug use is too. There are many reasons why someone would use illicit drugs. It's a complex, multifaceted problem. And as I suspect there could be from my eating bacon, there are real consequences of illicit drug use. Using illegal drugs is counterproductive for society, but people should not be denied the healthcare they need because they have made a bad decision. Finding a way to minimize the harmful effects rather than simply ignoring them makes a difference in healthy society. Naloxone hydrochloride, otherwise known as Narcan, saves lives regularly. Currently, emergency services personnel can intravenously administer the drug. Expanding access and allowing the same EMT to administer the drug intranasally makes it easy for these essential workers to get on with their day. At the same time, it may make a difference for a patient who needs to get back on the path to recovery. Drug use runs counter to a healthy mind, just like the bacon I ate this morning is counter to my healthy body. But unless you're a vegan, there isn't as strong of a moral stigma to the bacon. With that said, the Alliance would ask you to check your perspective, potentially, and consider the difference that supporting LD 1333 could make for our community. Thank you.
Thank you. Committee member questions for Ms. Morse? Seeing none, appreciate you being here today. Ms. Parrish, Whitney Parrish, welcome.
Thank you. Good morning, Representative Meyer and members of the committee. My name is Whitney Parrish, and I'm the Advocacy and Communications Director for the Health Equity Alliance and a resident of Hollowell. Health Equity Alliance is a nonpartisan, nonprofit public health and harm reduction organization that envisions and works toward a world where all people are valued and celebrated and health justice is realized for everyone, regardless of who they are, where they come from, or what their lives look like. I'm here to speak today in support of LD 1333 because all frontline emergency medical services providers must be able to appropriately respond to an overdose call in the most effective manner they can. So a little bit about Health Equity Alliance. As Director Smith mentioned, there are tiers of naloxone distributors, and Health Equity Alliance is a tier 2 distributor. We receive our naloxone, intranasal naloxone, from the city of Bangor, a tier 1 distributor. So I'm grateful to Director Smith for explaining that a bit to the committee. We operate 7 CDC certified, syringe service programs across northern, down east, and mid-coast Maine. We distribute intranasal and intramuscular naloxone at every location, as well as provide the education to administer, as you've heard about, for this safe, effective, and life-saving drug. In fact, I'm qualified to train on the administration of both modalities, and I carry my own intramuscular naloxone because I love people who use drugs, people on long-term opioid regimens for pain management, and because it is the right thing to do. Both intramuscular and intranasal naloxone are easy to use, effective, and should be in the hands of anyone who might be in the position to reverse an overdose. So very specifically, the folks who are closest to people who use drugs, their friends, their family members, themselves, and emergency medical services. Anytime an overdose call is answered by EMS providers, we view this as an extremely positive thing. Giving them the tools they need to save lives in the quickest, most effective ways possible is imperative. Closing this gap in statute will do just that. We are also very supportive of Amendment A, allowing EMS providers to distribute naloxone for the reasons outlined by Representative Zager, Director Smith, and Dr. Pollard. I do want to mention that one of the main reasons we observe that someone chooses not to go to the emergency department after an overdose call is because of the threat of discrimination and criminalization. There should be no barriers to someone staying alive and well. We strongly urge you to vote ought to pass as amended on LD 1333 and thank Representative Zager for his leadership on working to stem this tragic escalating wave of preventable overdose in our state, overdose death. Thank you for your time, and I'm happy to answer any questions.
Questions from Ms. Parrish? Seeing no hands up, we thank you for being here today and for the work that you're doing.
Thank you.
Finally, we would welcome Mr. Dan Moran.
Thank you, Representative Meyer and Senator Claxton in absentia. My name is Dan Moran. I'm Director of Communications and Government Affairs for the Maine Medical Association. Our office is in Manchester. I was born and raised in Lewiston, and hello, Representative Craven. I grew up on Brolt Street by Bates College, and Representative Connor, welcome to the committee of this session. I have plenty of fun facts about your districts, some of which I can say and some of which I can, including No Name Pond in Representative Connor's district. So we'll talk about that another time. But I'm glad to be before you today to talk about the amended version of LD 1333. I greatly appreciate the work of Mr. Smith, the former executive director of the Maine Medical Association, also Dr. Zager. Senator Moore, I want to thank you again for allowing us to intrude your hearing on your bill earlier about this very important issue. Of course, members of the committee for indulging us with this amendment, and Anna and Aaron, of course, who without them, none of this would actually be possible, as you all know. So the amendments, we support both of them. The ability for a chief medical officer, medical director, or other administrative prescriber employed by a licensed hospital currently has access to the PMP, but that's not the case for larger independent community-based practices. Although we represent 4,300 physicians, residents, and medical students, they are across all specialties, organizations, and practice settings, including the independent practices. We also support the amendment for our EMS colleagues and thank Mr. Hurley for his work and their work to fight this epidemic. And we hope you'll ought to pass as amended and include both amendments in the bill. And we look forward to working with you on other bills in the future. Thanks.
Thank you. Questions for Mr. Moran? Seeing none. that concludes testimony on 1333. I would ask the committee if they've got any requests for additional information from our analyst. Seeing no hands up, no requests, I will close the hearing on LD 1333 and move on to open the hearing on LD 789, presented to us by Representative Genevieve McDonald, and I see she is here. Welcome, Representative McDonald.
Thank you. Good morning, and it's nice to see everybody today. Senator Claxton, Representative Meyer, distinguished members of the Joint Standing Committee on Health and Human Services. I am Representative Genevieve McDonald of Maine House District 134, and I am testifying before you today as the sponsor of LD 789, an act to expand administration of life-saving opioid medication. This bill is a concept draft that was created as a placeholder in the event suggestions came forward during the first session of the 130th Maine Legislature. It is available if the committee would like to use it as a vehicle to advance ideas forward. Thank you for your time, and I would be happy to answer any questions from the committee.
Thank you very much, Representative. I'm thinking there are likely not many questions from the committee on this LD, and we thank you for allowing the committee to use this for further work going forward.
Thank you.
I will close the hearing on 789 unless our analyst has anything to add. Nope. And since you are the sponsor of the next LD on our schedule, I would welcome you to provide an introduction to LD 1177. Representative McDonald.
Thank you, Representative Meyer and members of the committee. I am also the sponsor of LD 1177, an act to increase access to intranasal naloxone hydrochloride for syringe services programs. The program this bill seeks to address is already permitted under current Maine statute, and so this proposed legislation is drafted is not necessary at this time. This bill is available if the committee would like to use it as a vehicle to advance ideas forward. Thank you for your time, and I'm happy to answer any questions.
Questions from the committee? Seeing none, once again, our thanks and gratitude for allowing us to use this LD for further work from the committee.
Thank you for your time.
Sure. Have a great day and a great weekend.
You too.
Moving on. And we're moving rather quickly, so I'm going to ask Carrie if we've got Representative Dodge available.
She will be here very soon.
Okay. Given that it's 9:43 by my clock, why don't we take a 7-minute break to 9:50? Yes, Representative Connor agrees, and we'll see you back at 9:50.
Yeah, no, it's fine.
It's 9:50. We're back after a short break. I see Representative Dodge has joined us. I would ask that you unmute and welcome, and present to us on LD 1428, an act to increase the availability of nasal naloxone in community settings. Welcome, Representative Dodge.
Thank you very much, Madam Chair. Good morning, Senator Claxton, Representative Meyer, and esteemed members of the Health and Human Services Committee. I am Representative Jan Dodge of House District 97, which includes Belfast, Northport, and Waldo. I am here to present LD 1428, an act to increase the availability of intranasal naloxone in community settings. As you may know, Maine lost over 500 people last year to preventable overdose death. One of the best methods we have in preventing overdose death is making sure naloxone is available whenever and wherever it is needed. In working on this bill, I spoke with several organizations that distribute naloxone and interact with local groups about the level of need in our communities. The need is deeper than I and many others may realize, and the number of opioid overdoses appears to be growing. COVID-19 has negatively influenced social and emotional health and has been identified as a possible contributing factor to increased drug use and number of drug-related deaths. With only a few local libraries or community centers obtaining the life-saving drug and training their employees and volunteers to administer naloxone from a physician's standing order, I believe it is incredibly important at this time for Maine organizations to know they can carry naloxone in case of emergencies and to urge them to have it on their premises. Knowing that a form of naloxone was accessible at soup kitchens, Y's, after-school centers, and other community-based entities could save lives. While the intent of this bill can be captured through targeted education and a broad-based awareness campaign, I hope as a committee you will also preserve the spirit of the bill. More needs to be done to reduce overdose deaths. Efforts are underway to expand availability in Maine schools. Existing education and pharmacist statutes are being reviewed, and strategic planning is ongoing. To make sure we have a bill in place for possible legislative action in the second session of the 130th to increase access to this safe, life-saving drug, I respectfully ask the committee to consider carrying over LD 1428. I make this request after consultation with Whitney Parrish of the Maine Health Alliance, who also consulted with Mr. Gordon Smith of the Opioid Task Force. I look forward to working with your committee and stakeholder groups to increase access to naloxone in either intranasal or intramuscular form. Thank you. I will try to answer your questions.
Thank you, Representative Dodge, for bringing this forward. Questions from the committee for the bill sponsor? I am seeing none. And before I ask Caitlin Morse to unmute and present, I would like to ask Senator Baldacci, who's joined us, to introduce himself.
Good morning. Thank you, Madam Chair. Good morning, committee members. I'm Joe Baldacci from Senate District 9, which is the city of Bangor and the town of Herman. Thanks.
Thank you. Ms. Morse.
Good morning, esteemed members of the Joint Committee on Health and Human Services. I have spoken with you previously. I gave you my bacon analogy, but look, I work with the Alliance for Addiction and Mental Health Services. And on behalf of the Alliance, I am here to speak in support of 1428. So I can speak to you about bacon again, or I can just tell you a little bit about my bacon analogy and where it comes from. There's a belief in harm reduction. And again, behavioral health recognizes that connection between behaviors and the health and well-being of the body and mind is essential. The Alliance works to make life easier for providers while believing that people who are suffering should be able to easily access the resources they need. While using illegal drugs is counter to productive society, people should not be denied the healthcare they need because they make a decision that's counter to productive community. Finding a way to minimize harmful effects instead of simply ignoring them makes a difference. And this bill enables community organizations, private or nonprofit organizations operating a facility to utilize nasal naloxone upon a standing order. Individuals working in the public with community organizations could see an overdose happen at any time, and this bill would position them to save a life. Narcan is side effect free and safe. Someone who is not exhibiting overdose symptoms, if they accidentally took it, nothing would happen. You can't take too much of it or abuse it. Organizations and people in positions to administer the drug should be trained, but training is easy. And in fact, because of the pandemic, you can actually receive the training online now. Access to appropriate treatment for people in all stages of substance use disorder is an issue we feel very strongly about at the Alliance, and we would like you to support this bill. In the meantime, I will just share that there's a great website, harmreduction.org, and I'm relatively new to the Alliance, and so it was one of the few places I went to get great information and really understand harm reduction as I was researching and learning about this issue. So I won't give you my bacon analogy again, although certainly that is how I have connected to this issue. Do you have any questions? Anything I can do at this point?
Questions for Ms. Morse? Yes, Representative Craven.
Thank you, Madam Chair. Actually, it's probably for Representative Dodge.
Go ahead.
So maybe you could elaborate a little bit on the suggestion to carry the bill over. Are you going to be working with the coalition to broaden it out by then? Is that the reason, or?
Thank you for the question. And I'm not sure that broaden would be the right term, but in talking with Ms. Parrish, there seems to be a state of flux right now. Of course, that may be forever, but there is a bill about naloxone in the schools. There is apparently some reassessment going on with the opioid task force. And so I'm not sure that there is a specific direction right now that this bill could follow or take. And so it was their suggestion, Ms. Parrish, in consultation with Mr. Smith and the opioid task force and several other organizations, that this bill could be the vehicle after a certain amount of dust settles in a few directions, that this would then be able to be a bill to take us to the next step. Does that answer your question, I hope?
Thank you. Yes, thanks.
Thank you.
Seeing no other hands up with questions for either Ms. Morse or Representative Dodge, I would ask the committee for any further information from our analyst. Seeing none. Thank you, Representative Dodge, and I'll close the hearing on 1428.
Madam Chair, I did have a request if we could, for some additional information.
Yep.
A number of communities have equipped their police forces with Narcan. Bangor did about 5 years ago, and it saved lives. I was wondering if we could get some feedback from either the Mayor's Coalition or the Maine municipal people about the experience of local police or fire departments with the use of Narcan. I think it's been generally a positive experience. I know, as I said, in Bangor, it's saved lives and it's an important tool. It's not going to solve the problem, but it's an important tool. If we get feedback from communities that have been using Narcan regularly about any feedback about the bill or anything, that would be great from MMA or the Mayor's Coalition.
Okay. Nope, Seeing no other hands up. Thank you. I will open it.
Have a great day.
You too, Representative. Up next to introduce LD 1487 is our own Representative Holly Stover. Welcome, Representative Stover.
Thank you, Representative Meyer. And I know Senator Claxton isn't here with us, but to my fellow members of the Health and Human Services Committee, my name is Holly Stover, and I represent House District 89, including the towns of Boothbay, Boothbay Harbor, Southport, Edgecombe, Westport Island, and part of South Bristol. And I'm here today to present LD 1487, which is a resolve directing the Department of Health and Human Services to seek a waiver for additional medication-assisted treatment for certain persons with substance use disorder up to 30 days prior to their release from incarceration. As many of you know, I work in a community-based collaborative providing addiction outreach services with the Boothbay Harbor Police Department. In my work, I've worked with several people who have had periods of incarceration, often for reasons related to their illicit drug use. The transition from incarceration to the community can be very challenging. The Department of Corrections and county jails have worked hard to create a smooth transition back into our communities for persons in their custody. But through no fault of any party, gaps in treatment and coverage still exist. The people at highest risk for overdosing on opiates are those suffering from substance use disorder immediately after being discharged from incarceration. While medication-assisted treatment is available in nearly every correctional facility in Maine, thank goodness, not all treatment options are readily available. This usually means more expensive medications, such as long-acting injectables, are not available. And that's something that this bill is seeking to address. For some people, long-acting injectables provide significantly better outcomes for those that struggle with diversion as a result of their addiction. Long-acting injectables also reduce the amount of time correctional staff spend that is necessary to individually supervise inmates taking a dose of medication every day. And for those of you who were part of this committee in the 129th, you remember we went to the program at Warren and we saw that there were, I think, 3 guards that had to supervise the inmates taking medication orally. And by providing injectables to that population, you could eliminate all of that intensive staff time. Expanding main care coverage to this population prior to their release will make additional forms of medication-assisted treatment available and reduce the risk of overdose and overdose-related deaths for inmates leaving incarceration and improve their transitions back to the community. There are some other people who will be speaking to this today, and I thank you for consideration of this bill.
Thank you, Representative Stover, for bringing it forward. Questions from the committee for the bill sponsor? Seeing none, we will move to Mr. Mercer. Welcome.
Thank you.
Mr. Mercer, we've got a very bad connection. Not well at all. You might want to minimize your video and speak to us. I'm not seeing him now. Perhaps he's going to sign back in, so I would go to Ryan Page. Welcome.
Hello, can you hear me?
We can.
Perfect. I'm doing this from work in my vehicle, so
okay.
Please bear with me.
Okay, hopefully pulled over to the side of the road.
Yes, definitely not driving.
Okay.
Thank you so much. I'm just gonna pull up my testimony. So, give me 1 second here. Can you still hear me?
We can.
Beautiful. You hear me now? Marshall's in.
We'll come back to you, Marshall. Hang in there. Thanks. Go ahead, Mr. Page.
Okay, thank you. Senator Claxton, Representative Meyer, and esteemed members of the Health and Human Services Committee. My name is Ryan Page, and I am an organizer with the Maine Recovery Advocacy Project, and also a person in long-term recovery. I am also a person that has lived experience with substance use disorder and incarceration. I come to you today in support of LD 1487. This bill will allow for residents of Maine's jails and DOC to receive Maine care 30 days prior to release. The ability to procure health insurance before release will allow residents access to more evidence-based options for the treatment of substance use disorder while incarcerated, and will also remove an enormous barrier in the transition to reentry and continuity of care. These barriers increase recidivism and create potentially life-threatening scenarios for so many people. While in active addiction, I was incarcerated multiple times. I can't help but think that if there were adequate treatment options available to me and a plan of release that outlined and stabilized those options upon my release, that the amount of times I returned would have been significantly lowered. I continued on a path of suffering and self-destruction for many years, culminating in multiple overdoses that nearly claimed my life. I am fortunate to be here today to share this story. Unlike a friend of mine, Eddie. What happened? Sorry, I lost my thing.
Okay.
Unlike a friend of mine, Eddie, who was recently released from incarceration and subsequently had a recurrence of use. This recurrence ended Eddie's life. I believe that had he been provided with treatment and had a well-established plan of release, he would still be alive today. We have, as a state, made so much progress in the understanding and treatment of substance use disorder. I ask you to vote in favor of this bill to build on that progress and give our people the best chance possible at success and ultimately survival. I'm available for any questions. Thank you for your time.
Thank you. Questions from the committee? Seeing none, thank you for sharing your story here today.
Thank you.
Mr. Mercer,
Hello, can you hear me?
we can.
All right. Good morning, Senator Baldacci, Representative Meyer, and members of the Health and Human Service Committee. My name is Marshall Mercer. I am an organizer for Maine Recovery Advocate Project. I'm here in favor of LD 1487. I'm also a student of recovery. What I mean by that is I remain teachable in my recovery walk and continue to share the tools I learn on the way to help those to continue on or help those find their path. And that being said, sometimes that involves access to whatever medication one may need on their path to recovery, which 9 out of 10 times, many inmates who have fallen on hard times may or may not have the proper access to the medication they need due to lack of insurance. Being already part of an incarcerated population is hard enough. Add a substance use disorder in the mix and the fear of entering society because not having the support needed could be a disaster waiting to happen for those entering back into society and society itself. Having the proper tools like having proper medications or insurance needed before entering the public, so upon entering back into society, one can get the help they need, which is what's best for those who are getting out and the public as well. I say all this through lived experience. Getting back out without proper help needed could be life or death, because having no insurance, I couldn't get the treatment I needed to get when I got out. And I tried, but not being able to get because the lack of insurance led to a relapse in my behavior, which sent me to a path of destruction, which led others like me on that path as well, as the whole community felt it. But all this can be avoided, and this can start with you guys. So we come to you fine folks and hope that you hear what we're saying and we can give insight in your decisions you're making. And thank you. I'm here for any questions.
Thank you. Questions from the committee? Seeing none. We appreciate you being here today. You too. And finally, Caitlin Morse, welcome back.
Thank you. I'm not going to talk to you about bacon this time around. Good morning, esteemed members of the Joint Committee on Health and Human Services. I am Caitlin Morse, a resident of Westbrook and the Policy Associate of the Alliance for Addiction and Mental Health Services. On behalf of the Alliance, I am here to speak in support of LD 1487. The Alliance represents Maine's safety net, community-based mental health and substance use treatment agencies. We advocate for sound policies and evidence-based practices that enhance the quality and effectiveness of Maine's behavioral healthcare system. It is estimated that more than half of prison inmates deal with mental health concerns. Change and transitions are not easy for the best of us. Imprisonment and reintegration is likely an especially difficult phase of life. Behavioral health recognizes that connection between behaviors and the health and well-being of the body and mind is essential. When someone leaves a facility without healthy connections or proper treatment, as we've heard this morning, the difference could be life or death. People should be able to easily access the resources and care that they need. When someone who has been imprisoned returns to the community, risk factors for substance abuse disorder multiply. We know that drug overdose is a leading cause of death during the first few weeks of reintegration among formerly incarcerated people with opioid use disorder. According to the American Society of Addiction Medicine Public Policy Statement on Treatment of Opioid Use Disorder in Correctional Settings, more than half of individuals with opioid use disorder reported a history of involvement in the criminal legal system, and nearly 2/3 of prison inmates have a history of substance abuse disorder. Limited access to proper treatment is dangerous. It isn't smart from a healthcare perspective, and it has the potential to become a drain on resources and create harmful consequences for the community. Medication-assisted treatment, or MAT, is a comprehensive program that combines the use of medication, counseling, and behavioral therapies. When tailored to the needs of a patient, this is an effective approach to opioid use disorder. When offered to people who are leaving and have been in the prison system, it could reduce the boomerang effect. LD 1487 authorizes the state of Maine to seek a waiver from the United States Department of Health and Human Services, Centers for Medicare and Medicaid Services, for matching federal funds to support medication-assisted treatment for persons with substance use disorder who are incarcerated for up to 30 days prior to their release. Access to appropriate treatment for people in all stages of substance use disorder is one of the issues we feel strongest about at the Alliance. And with this in mind, we ask you to please consider supporting LD 1487. Thank you.
I've got to unmute myself. Thank you for being here once again. Questions from the committee for Ms. Morse? Seeing none, we would welcome Mr. Cheney. There you go. You're still muted.
Good morning. Good morning. My apologies. I was unmuting. Good morning, Senator Claxton, Representative Meyer, and members of the Health and Human Services Committee. It's certainly my privilege and honor to give testimony in support of bill number LD 1487. This bill would allow the use of long-acting 30-day alternative to the current daily buprenorphine regimen, which would reduce the incidence of post-release overdose mortality, reduce diversion and trafficking in correctional settings, provide significant criminal justice enforcement cost savings, and ensure a stable platform for medical and clinical treatment, both pre and post-release. My name is Timothy Cheney, and I live in Walpole, Maine. The testimony I submit today is both experiential and professional. I am the founder and owner of Enso Recovery, a licensed substance use disorder and mental health treatment program that provides medication-assisted treatment services for persons suffering from opioid use disorder in the Sanford and Augusta communities and the Two Bridges Regional Jail and Kennebec County Jail. Additionally, we operate 4 gender-specific certified medication-assisted recovery residences with 52 beds in both communities for post-release individuals who have no housing. I am a person in abstinence-based recovery from opioid addiction for 39.75 years and previously spent 13 years in medication-assisted recovery, which saved my life. In my former life, before entering recovery, I was a homeless heroin addict in New York City, Boston, and New Haven. After entering recovery, I became a published epidemiologist for NIDA, the National Institute of Drug Abuse, the acting director of the City of Boston Methadone Program at the Bradstone Street Clinic, the director of research for the City of Boston, the director of addiction services for New Haven Community Correctional Center, a guardian ad litem post-retirement, the founder of a foundation dedicated to saving lives through funding harm reduction initiatives, including naloxone and syringe exchanges, and the chairman of the International Division of a publicly traded company and the recipient of a presidential, congressional, gubernatorial, and addiction industry award for my work in the substance abuse and child welfare. I retired in 2002, and in 2017, I'm scrolling down, rescued 2 failing opioid treatment programs. Since 2017, I personally invested, and I normally don't say this, but I will, personally invested $1.5 million to treat and shelter those who have been left behind. Medication-assisted treatment is the gold standard in treating opioid use disorder. It is the only treatment modality which is considered to be evidence-based treatment for opioid use disorder. This claim is supported by 49 years of rigorous outcome data and is endorsed as such by the American Society of Addiction Medicine, the Substance Abuse and Mental Health Services Administration, the World Health Organization, the Center for Disease Control, the National Institute of Drug Abuse, and numerous other organizations and associations worldwide. Recently, MAT has been adopted by many prisons and county jails throughout the country to treat persons incarcerated diagnosed with OUD, which incidentally 65% meet the DSM-IV criteria for this disorder. Currently, the standard method of administration is daily sublingual buprenorphine or buprenorphine / naloxone, which is Suboxone, due to cost constraints. Although these medications are highly effective, it has become the #1 traffic substance in correctional environments. This is partially a result of the ease of diversion of oral medication. In Maine, over the past 2 years, these are district attorney figures, approximately 90% of seized traffic contraband is buprenorphine or Suboxone, which has resulted in substantial costs to the correctional facilities, investigation costs, prosecution costs, and additional incarceration costs for people adjudicated guilty. I would like to ask the committee to understand that this population is suffering from an addictive disorder, and most have adopted criminogenic thinking and behavior, and therefore the probability of diversion exists. Another, another significant factor in diversion is coercion by fellow inmates for persons receiving treatment to divert their medication, which introduces a personal safety consideration for persons receiving treatment. From our experience in operating medication-assisted treatment programs in the jail, the risk of diversion would be significantly diminished if the financial constraints were eliminated on alternative methods of administration and the long-acting buprenorphine injection Sublocade was covered by state and federal funding. It would be clinically beneficial as persons on medication would not be preoccupied with their daily dose and therefore more engaged in their clinical treatment, and financially cost-effective for both the Department of Correction and the state. Additionally, it would benefit persons being released from incarceration as it would eliminate the possibility of a gap in treatment post-release, which would reduce post-release overdose mortality by ensuring continuity of treatment. The COVID-19 pandemic has impacted jail populations, and release policies have become more lenient and unpredictable, putting people at risk upon release without continuing care. Persons suffering from addictive disorders have the right to the same quality of treatment as those suffering from any other life-threatening disease, and the additional upfront cost not only should not be, but cannot be a consideration in their treatment. For many, this is a question of life and death, as illustrated by Maine's escalating overdose mortality statistics. I urge the legislative members present today to carefully consider the ramifications of this resolve in terms of the value we place on preserving human life. This is a healthcare issue and a social justice issue, not a criminal nor a moral issue. I ask the committee to consider the lives that will be saved and to ask yourself, how would you feel if your child or your spouse was incarcerated and denied access to this medication, and post-relief they died in an alley or in a public bathroom stall? Thank you.
Thank you, Dr. Cheney. Questions from the committee? Seeing none, thank you for sharing that remarkable story and for the work you've done and continue to do.
Thank you.
I would like to offer Senator Claxton an opportunity to introduce himself.
Thank you, Madam Chair. My name is Ned Claxton, and I represent Senate District 20, which is Auburn, Minot, Mechanic Falls, Poland, and New Gloucester.
Thank you. Up next, Mr. Newell Auger, welcome.
Thank you, Chair Meyer and Chair Claxton. In my 15 or 20 years of doing this, I don't think I've had to follow anyone's testimony as powerful and as effective as Dr. Cheney's, but I'm going to try. My name's Newell Auger. I am a resident of Yarmouth, a lawyer with Pierce Atwood. I'm here on behalf of Indivior. Indivior is a global pharmaceutical company working to change patients' lives by developing medicines to help treat addiction and serious mental illness. And we're here in support of Representative Stover's bill. Indivior's medications play an essential role in treating OUD. The company has been part of the national effort to destigmatize opioid use disorder, as Dr. Cheney referenced, and has been advocating that opioid use disorder be recognized as a treatable medical condition and not as a moral failing. And the objective is that more patients in Maine and throughout the world will have access to evidence-based treatment for chronic conditions and co-occurring disorders that you've heard Mr. Page and Mr. Mercer discuss. I don't want to go into the impact of the opioid epidemic. This committee is well aware of that, but I would want to point out, at least because I think you've gotten a letter from the department about the federal prohibition against persons incarcerated receiving Maine care coverage. So I want to speak to that if I could. First is to note that the state of Kentucky has already submitted an 1115 waiver to do exactly what Representative Stover's bill is asking this committee to ask the department to do. And actually what I will do when we're done with this hearing is send you that link, or I'll send it to Kerry so that all of you can see it and see the rationale behind the state of Kentucky's request that is currently being considered by CMS. The state of New York is currently under serious consideration, both by their House of Delegates and by their state Medicaid state Medicaid department. The Congress has considered legislation to allow Medicaid coverage to persons in the criminal justice system up to 30 days pre-release. And the Medicaid Reentry Act, which has bipartisan support in the House and Senate, I might add, is part of that effort. And so I guess I would say to you as a committee, if you're sort of
30 seconds, please.
Sure, betwixt and between on this, if Maine makes this request and gets it, patients win, families win, employers win, and Maine wins. If Maine makes this request and it's denied, we are on the front line of solutions to the opioid epidemic within this pandemic, and on the front line of solutions to the costs associated with recidivism, and on the front line of supporting people who are in recovery. So with that, I'd close, and I will send Kerry the link to the Kentucky 1115 waiver request. And happy to answer any questions.
Sure, thank you, Newell. Questions for Mr. Auger? Seeing none, I would welcome Ellen Farnsworth. Ms. Farnsworth. Ellen Farnsworth. Ms. Farnsworth?
Yes, I'm here. Okay.
Welcome.
Sorry. All right. The Senator Claxton and Representative Meyer. My name is Ellen Farnsworth, and I'm a nurse practitioner that has been in the field of doing medicated assisted treatment for a while now, and I'm writing to request your support of LD 1487 to support MAT for persons with substance abuse disorder, especially for 30 days prior to the recovery, or prior to the release, rather. I have seen firsthand the revolving door of patients that come out of incarceration and immediately relapse to either overdose or sometimes occasionally death. This can be prevented if substance abuse treatment is either continued in prison or jail, or at least begun 30 days before their release. And make sure I've submitted written testimony, but to add to that, I think we need to have case management to make sure they get into either drug court for treatment, they either get into community-based treatment providers, but to make sure that link happens so there's no gap in their treatment, so they have a chance at recovery. In 2017, the opioid crisis was declared a national emergency for public health, and overdose is the leading cause of death among formerly incarcerated, opioid-dependent, incarcerated individuals, especially in the first few weeks after release. MAT during incarceration, prior to release, and referral to drug court and/or community-based services can be effective deterrents to relapse, overdose, and death. We have seen increasing numbers of overdose deaths during this pandemic. The Substance Abuse and Mental Health Services Administration, SAMHSA, and the American Society for Addiction Medicine, ASAM, the leading agencies in the treatment field, support medication-assisted treatment as the gold standard for persons struggling with chronic disease of substance abuse disorder. I refer you to the evidence-based resource guide that SAMHSA has on their website, as well as ASAM's national practice guidelines that are also on their website. This resolve, directing the Health and Human Services to seek a waiver with federal matching funds, is important. It's going to bridge our incarcerated citizens from incarceration, community treatment to prevent relapse, overdose, and it is imperative with the rising deaths from overdose. And we, the Nurse Practitioner Association, respectfully request that you vote LD 1487 as ought to pass to provide medication-assisted treatment to persons with substance use disorder and incarceration. Thank you for your attention to this important bill.
Thank you, Ms. Farnsworth. Questions from the committee? Seeing none, that concludes testimony, unless I'm missing someone, and I don't think that I am. That concludes testimony on LD 1487. I would ask the committee if they've got any requests for additional information for Aaron. Seeing none, I will close the hearing on 1487 and turn to Aaron for any additional work the committee might have before them today.
Not today. Happy weekend.
Well, okay. That will, I'm guessing I won't get any opposition or resistance from the committee if we conclude our work today. We've had a long week, and I would entertain a motion to adjourn.
So moved.
Moved. Second.
All in favor? Have a lovely afternoon and a great weekend.
Hello, Representative Javner.